So in terms of comorbidity, so depression is one of those types of diagnoses that goes along with other conditions commonly. So depression frequently coexists with eating disorders, personality disorders, alcohol and drug abuse. So people who drink alcohol or take drugs might actually be self-medicating for their depressive symptoms as well. So those two can go hand in hand. And alcohol is a depressant. So you can see how that becomes a vicious cycle and co-occurs. Similar with anxiety disorders, depression can go along with anxiety as well. And if you look at sort of an Aaron Beck or a cognitive type of conceptualization, a number of the cognitive errors that people make who have depression or anxiety, like ruminating, you can see how a ruminative thinking style could feed depression, or if you're ruminating about the past and what you should have said or you should have done, how that could feed in depression. If you're ruminating about the future, what am I going to do? I'm never going to be able to get all of this done. I've got too much on my plate. You can see how that type of thinking would feed into anxiety, but the underlying thinking pattern is actually shared in terms of the rumination across depression and anxiety. So you can see how that presentation can often co-occur. So they can still be co-occurring, but you have to try to differentiate whether the depression was occurring before the substance abuse problem, and also what's the primary condition as well, because people can have a number of conditions actually, or a number of diagnoses, but you just have to be able to differentiate. And that's why it's so difficult, right? Because trying to identify the temporal sequence, well, what came first? Was it the depression or was it the alcohol? If they're still drinking a lot, are the depressive symptoms actually the result of alcohol? So you can actually see that it becomes actually quite difficult to tease apart those diagnoses, particularly when you don't have a detailed history on that person, and also even more difficult when that person might not be able to give you a particularly reliable historical account of their presentation as well. So very good question. Yeah. That reminds me, actually, somebody asked, why don't I just get a walking microphone so I don't have to repeat questions? It's because of the recording. If I'm walking around with a portable microphone, it's not recording through the system. So I would love to, because actually I'm somebody, I like to move around, so it's actually quite difficult to stand in this one spot for 2 hours, probably like you sitting in the one spot as well. But if you're wondering why I don't have that, that's why I'm standing here rather than strolling around with a microphone. Any other questions? Okay. So in terms of the course of depression, the onset, most people, so about 50% of people will have their first depressive episode when they're less than 40 years. The average onset is around about 32 years. And if that episode goes untreated, so whether it's untreated with medications, if they don't seek out, or if they don't seek out psychological therapy, so if it's untreated, that episode will typically last on average between 6 to 13 months. Knowing that this is on average, again, there's a lot of variability within that, but this is on average. And in terms of if the person does, however, seek treatment, most of those episodes will then be reduced from that 6 to 13 months down to 3 months. So you can see the big difference it makes when people are appropriately diagnosed and appropriately treated in terms of the impact on their life. And if we return back to the disability, the years lived with disability due to depression, you can see what a difference it would make in terms of years lived with depression and disability if people were accurate or appropriately treated. So that's a massive reduction in terms of the duration of symptoms. One of the problems is that people who take antidepressants, when they have found an antidepressant that is a good fit for them, what happens? They start to feel better. What happens when you start to feel better? Yeah, you start taking the medications. You know, you can call it compliance, but sort of compliance puts the blame on the person. But it's actually only logical across these conditions that when you start to feel better, you think you don't need to take the medication. We have the same problem with antibiotics, right? People don't take the full course of antibiotics so because they start to feel better. And so it's the same thing here. So when I present that type of information, I don't want you to just sort of label it as, oh, that's a bad, non-compliant patient. This person is just logically feeling better. The problem with that is that if they stop the antidepressant too soon, that can actually lead to relapse, and so where they can experience another depressive episode. And so this is building on what I was mentioning before, that around 5 to 10% of people that have an initial diagnosis of major depressive disorder will then go on to have a manic episode, which then pushes them more towards the bipolar diagnosis, which what we'll talk about afterwards. The average for that is around about 6 to 10 years after the first episode of depression. But again, as I mentioned before, that diagnosis becomes somewhat difficult because it's less common for people to actually present with a manic episode than it is for people to present with a depression. We don't like feeling depressed, but feeling energized and like you can take on the world and grandiose, that feels good. So actually a manic episode, often people don't present for that, and so that's why the actual diagnosis, they get assigned a depressive diagnosis rather than what might be more appropriate, the bipolar. So in terms of prognosis, so what this looks like in terms of the disease course going forward, major depressive disorder is a fundamentally cyclical disorder, and so unfortunately what that means is that it's not that you just have one episode, you recover or you get through that episode and then that's it, goodbye depression forever. That's the case for some people, but unfortunately it is a condition where once you have your first major depressive episode, it puts you at greater risk for a further depressive episode, which is what it means that it's cyclical, that you experience it, it goes away, it comes back, you experience it. And so the risk of that reoccurrence or experiencing that again is increased when you have more than one previous depressive episode. So the more episodes you have, the greater risk you have that it's going to become more and more frequent or recurrent. And also the risk of recurrence is increased when you have coexisting persistent depressive disorder, so that's when you have that lower level depression for about 2 years. You're also then at increased risk to have one of these major depressive episodes. Also, if we have alcohol and drug abuse problems within the context of depression, that also increases risk of recurrence of a depressive episode, as do anxiety symptoms as well. And so ideally, for the best possible long-term outcome, if we can catch this and nip it in the bud and keep the episodes as contained as possible so they get treatment, maybe they're on medications to get through that, if we can limit those number of episodes, that individual is going to have a better prognosis going forward. So that again highlights the importance actually of treatment for this disorder. And we have very good evidence-based treatments in terms of medications and psychological treatments for depression, which we will touch on later today. So any questions about depression before we move on to bipolar? Yes, so the question was, can I give an example of what the episode would look like? If you're a clinical psychologist, a large percentage of your load, your patient load, will probably be people with depression because it is so common. And it looks slightly different depending on the particular person. You know, some people can present and they actually have they might even present for anger management issues. And actually that anger management and that irritability is stemming from an underlying depressive episode. In my particular line of practice, because I do work with people that have chronic pain, it's very common with people with medical conditions to experience symptoms of depression, which of course then adds to fatigue, lethargy, and a lot of negative thinking patterns as well go along with that, that I'm useless, I'm broken, I'm worthless, I'm unlovable, all of those types of negative thinking patterns. And that actually is a symptom or a presentation. That is depression. That's depression talking right there with those thought processes. And all of that, yes, we can work on that with treatment, but it's a symptom. So people that live with people with depression get frustrated because they think, just snap out of it. But you don't tell people to snap out of diabetes, right? So it's quite similar. This is a disease process. And so we have to have appropriate treatments to target those symptoms. I think that's important to notice that really it is like a medical condition like diabetes in a way. Same with all of the psychological disorders that we cover here, abnormal psychology. And there's a piece that's workable. I think that's the key piece too, is that when you have one of these diagnoses, it is workable. There are things that we can do. There are treatments that we can apply to shift you towards the highest level of functioning that is possible. And so really, when you're looking at somebody with depression, it's not like you can just say, this is what the archetypal person with depression looks like.